The topic for today's discussion is the thyroid gland, that is the structures and covering of the thyroid gland. So, if you have seen the patients with the thyroid gland inflammation, you can see a swelling in the front of the neck. That swelling of the thyroid gland, that you call it as goiter. Okay. Any swelling of the thyroid gland in front of the neck, that you call it as goiter, and it moves with the deglutition. We see the details of it. The thyroid gland is a gland which present anterior to the trachea and also to the larynx, and it extends from the vertebral level C5 to T1, and it extends from the oblique line of the thyroid cartilage to the fifth tracheal ring. So, the vertebral extent of the thyroid gland, it's from the C5 to T1, that is the extent. And if you see in relation to the trachea and then larynx, it extends from the oblique line of thyroid cartilage to the fifth tracheal ring. So, the presenting parts, the thyroid gland present two lobes. You will get a right lobe and a left lobe, and each lobe is connected by means of a small part that we call it as isthmus. So, if you consider a single lobe, it is pyramidal in shape and it presents the parts, that is the apex, base, and it presents three surfaces. We see the surfaces later. So, it presents an apex and a base. So, the apex is pointed upwards and it extends up to the oblique line of the thyroid cartilage. And the apex, it's sandwiched between, it present between two muscles, that is the inferior constrictor, and then you will get another muscle, that is the superior thyroid muscle. You will get two muscles, that is posteriorly inferior constrictor and anteriorly superior thyroid muscle. So, as it is sandwiched between two muscles, any swelling of the thyroid gland won't be extend beyond this oblique line of thyroid cartilage because of the attachment of the muscle. And the apex also related to the nerves and vessels, that is the superior thyroid artery and external laryngeal nerve. So, the apex of the thyroid cartilage, the apex of thyroid gland extend up to the oblique line of thyroid cartilage, and it's sandwiched between two muscles, and it's related to the artery, superior thyroid artery, and the nerve, external laryngeal nerve. And the base is related to the structures, that is the inferior thyroid artery, and you'll get the nerve that we call it as recurrent laryngeal nerve. If you see the structures near the apex, the artery and the nerve diverge near the gland. So, ligature of the artery will be done closer to the gland, and here near the base, the artery and the nerve are approximates closer to each other when it comes to the gland. So, ligature of the inferior thyroid artery during thyroidectomy will be done away from the gland. So, here the artery, superior thyroid artery is ligated nearer the gland, and the inferior thyroid artery is ligated away from the gland. So, surfaces, we come to surfaces. I told there are three surfaces. So, here you will get the surface, that is the lateral surface, anterior lateral surface, and then posterior lateral surface and a medial surface. So, three surfaces, you will get the anterior lateral surface, medial surface, and posterior lateral surface. So, anterior lateral surface related to the muscles, that is the sternothyroid, sternohyoid, and superior belly of omohyoid, and then anterior border of sternocleidomastoid. And then medial surface related to two tubes, that is the pharynx and continuous with esophagus, and the larynx continuous with trachea. These are two tubes, and related to two nerves, that is the recurrent laryngeal nerve and then external laryngeal nerve. And then it's also related to two muscles, that is the inferior constrictor muscle, and then another muscle, that is the cricothyroid muscle. So medial relations, medially it's related to the two tubes, that is the larynx continuous as trachea and then pharynx continuous as esophagus, and two nerves, that is the external laryngeal nerve and then recurrent laryngeal nerve, and two muscles, that is the inferior constrictor muscle and then cricothyroid muscle. So during the time of enlargement of thyroid gland, it enlarges and compresses these structures, and then it leads to the complications. If it is extended and then compresses the trachea, okay, that leads to the condition that you call it as dyspnea. So that is the shortness of breath, and it compresses esophagus, it leads to the condition that you call it as dysphagia, that is difficult in swallowing, and laryngeal nerves leads to the paralysis of the laryngeal muscles, that you call it as hoarseness of voice. And then posterior lateral relation, it's related to the posterior lateral, it's related to the carotid sheath and its contents, and more posterior it's related to the here, almost here you will get a structure that you call it as sympathetic chain. So when it enlarges, it also enlarges and compresses these structures. If it enlarges posteriorly, it compresses the carotid sheath and leads to the posterior displacement, and then further if it enlarges, it compresses the sympathetic chain and it leads to the condition that we call it as Horner's syndrome. So when it enlarges, it compresses the nearby structures, related structures. We'll come across once again. Medially, if it enlarges, it compresses the trachea, leads to shortness of breath. Esophagus leads to difficulty in swallowing. Laryngeal nerve, hoarseness of voice, and then carotid sheath leads to the posterior displacement of the structures, and sympathetic chain leads to the Horner's syndrome. Okay. And borders, if you take the lobe, you will get two borders. You will get an anterior border and you will get a posterior border. So the anterior border related to the vessels, that is the anterior branch of the superior thyroid vessels, and then posterior border related to the important structure, that is the parathyroid glands. So the parathyroid glands are related to the almost adherent to the posterior border, and during the procedure of thyroidectomy, the surgeon should be careful to remove the thyroid gland without removing the parathyroid gland. So that comes the end of the lobes. So next, the connecting part that you call it as isthmus. The isthmus is a small structure which is 1.25 centimeter when it measures on any side. Okay, lengthwise and breadthwise it is 1.25 centimeter. And then from the isthmus you will get a small extension. This extension that you call it as pyramidal lobe, and in some cases you will get another fibromuscular tissue that you call it as levator glandulae thyroideae. So these are the things related to the isthmus. When you come to the measurement of the lobes, it measures 5 centimeter in length, and then 3 centimeter in breadth, and then 2 centimeter in thickness. So apart from this, it weighs about 25 grams. Anything beyond this size, that leads to the condition that we call it as goiter. And when it comes to the coverings of the thyroid gland covered by two coverings. One is the innermost covering that we call it as true capsule. The true capsule is formed by the peripheral condensation of the stroma, and then the outer covering which is formed by the pretracheal fascia, which forms the outer covering. So the inner covering that you call it as true capsule, and then outer covering that you call it as false capsule. So, you will get two coverings, inner covering, that is the peripheral condensation of the connective tissue, that you call it as true capsule, and an outer covering, that is the false capsule. So, when you see the outer covering, that is a false capsule that is formed by the pretracheal fascia, it splits up and encloses the gland, and posteriorly, posterior part of the lobe, it condensed and forms a ligament, that you call it as ligament of Berry. And then superiorly, it also attaches to the thyroid cartilage, that is oblique line of thyroid cartilage, and to the hyoid bone. This is the reason why the thyroid gland moves along with the deglutition. So, this is the ligament of Berry. During the time of thyroidectomy, the surgeon should identify the ligament of Berry and it should be removed. And as I told, there are two capsules. One is the innermost true capsule and the outer false capsule. And here you can see the venous plexus of the thyroid gland present inside the true capsule. So, in order to avoid hemorrhage, the plane of cleavage of the thyroidectomy should be made between the true capsule and false capsule, and thyroid gland should be removed along with the true capsule. So, the hemorrhage can be controlled.